I'm Sarah Gander, pediatrician here with Horizon Health and in St. John Zone 2. And it's very funny to be able to do this presentation and watch now 198 participants join the call. I don't often get too nervous, but it's fun to see those numbers climb up as I'm starting to present. So thanks again for your time today. Um, as Pam mentioned, we're talking today about our project Exposed, examining the generational impact of maternal substance use and alcohol use on family health and social adversity. And I'll explain where this data came from and why we wanted to be involved in it and why it's important for a pediatrician to care about this data. And then some data for you guys to be able to kind of chew on and understand about our community and hopefully lots of questions. So first, I would just like to, oh, if it lets me move forward easily, acknowledge the land that we're meeting on today, and in particular, just acknowledge that a lot of our patients and families don't necessarily disclose their Indigenous ancestry to us when we meet with them, and it's after building relationships that we really begin to understand some of the Indigenous roots, and certainly can even begin to appreciate even more our Wolastoqiyik land, and particularly when you work near the hospital, you get to see that beautiful and bountiful river every day. As we mentioned, these are folks who are here today. On our first slide, we mentioned quite a few other people, and I'll mention in a minute some of the funding that went behind this. But as all of you, I'm sure, realize and know that research and data collection and outcome measurement and program evaluation, none of that or should be done on your own. We have a wonderful team at MB Social Pediatrics, and so I'm very thankful to them, and they're available for questions at the end as well. And so just in terms of funding, a lot of the data that I'll present today was actually funded by CHR Policy Transformation Grant, which is a big honor for us to have been able to receive that grant. Many of you who are in the research world would know that New Brunswick does not get its proportionate amount of CHR funding. And so when you get one, it's very exciting. And at the end of this presentation, we'll tell you about next steps for that. We did have some support with this project from industry as well, which was Novo Nordisk, who has a very clear interest in the social determinants of health, and then the government of New Brunswick, and of course, Research NB. So first off, I want to talk to you about the Parent-Child Assistance Program. And so a lot of this data really stems from the fact that our government of New Brunswick is very interested in breaking generational cycles of poverty. And when we as a research team and as a clinical team really wanted to look at how to go as upstream as possible, that's when we started looking at what we could do to help women who disclose drugs or alcohol use during pregnancy. And so we brought the promised and proven practice from the University of Washington to St. John and implemented the Parent-Child Assistance Program, which is a 3-year advocacy and support program for women who use drugs and alcohol during pregnancy. And we did that in around 2017 with help from the government of New Brunswick, and was able to run it. It continues to this day. And what's important is that we also aligned with that very rigorous and robust data collection, because when women were enrolling in the program, whether that be by referral from a clinical service like the neonatal intensive care unit, from the prenatal clinics, or even self-referrals or bringing in people from the community that were friends or family members, then we were really particular about understanding their experience and being able to later present data like we are today about their outcomes and other places that they're interacting with the system. And so PCAP is all about connecting folks to services. We have a lot of really great resources and services in St. John and in New Brunswick, but what we find with more vulnerable or marginalized populations is that being able to connect to those services, being able to have the executive functioning to be able to navigate those services, particularly as they jump sectors, and particularly as people are living in poverty and a lot of trauma and toxic stress, this becomes very difficult. So we like to say we walk alongside our folks and our families to be able to connect them to services and hopefully impact their outcomes later. So this picture is the current three PCAP advocates, is the term that we use: Kelly, Haley, and Lauren, who have done incredible work. There are advocates who came before them and hopefully advocates who come after to be able to really impact the lives of, many women in our community over the last 5 or 6 years, and over 170 referrals. Also, just a little note on DataNB, just in case people aren't familiar. The data linkage is a really important way of doing policy work and also just looking at different sectors. I'm sure you can appreciate I live in the health sector most of the time, so we collect our own data. Our computers, for the most part, sort of talk to each other by times. But to be able to jump to another sector, to be able to draw some conclusions or be able to link that data, so like with social development, or of course, I care a lot about education and even justice or public safety. Those sorts of things are very challenging, and so UNB has one of the most robust and successful data linkage systems. So previously MBIRDT, to be able to do that, and so we're really excited to be able to show some of the data for these populations that we've worked with, that can jump sectors and draw other conclusions. So hopefully, for those of you who have heard lots and lots about ACEs or adverse childhood experiences, just a reminder though, that trauma and adversity in childhood often leads to a lot of health harming behaviors and poor health outcomes. And that's why this is important for you guys, because while childhood adversity is something that just intuitively we want to decrease, we have to remember that the increasing adversity in childhood actually directly relates to mortality and morbidity later. And for some of the things that are very expensive for our system, but obviously very costly for individuals and their families. And so I'll point out in particular the physical and mental health concerns that, are the things that we're all trying to tackle in the healthcare system. So, heart disease, diabetes, mental health, COPD, directly related to how much adversity you've had in childhood. And also those behaviors that also contribute to poor health outcomes. And really, again, are just on a systems based and a policy based level, very important, absenteeism from work, lack of physical activity, and then, of course, that cycle because you get into substance use disorder again. And that tie to adversity is that we just know that people who use drugs and alcohol during pregnancy are not necessarily people who don't know that they shouldn't. They're using drugs and alcohol during pregnancy because of their circumstance, because of the history that they've had. And so then we get into these cycles. So again, we want to break these cycles. So, how do we decide to go after this from a data perspective? So and hopefully you're able to see maybe my little arrow just to orient you to, and my apologies that I'm presenting this all in English, but we do have translation today. So hopefully the slides are okay for this, but I'll point to where we have the parents who would be some of the women who are in our PCAP program, but we're talking about people who have disclosed drug or alcohol use on a systems-based data collection standpoint, their children, who will talk about the exposed group, then matching that group to another group of children who have not been exposed to drugs or alcohol, but have had similar other ways to match them, and then the general population. And then we also wanted to look, because we were so interested in that generational piece, about the parents of the parents. So that's where we get into the grandparent piece here. And some of the things that we really wanted to show you guys today is the demographics. So describe those populations, talk a little bit about how their socioeconomic status is in our community, their health and wellness, and then system usage and cost. The slides are a little leggy here. And what we also did is look for different policies and approaches to these populations that currently exist and really looked at some of our stakeholders to say, can you tell us what you think is missing, what your experience is, so we can, after we compile this information, hopefully be able to make some recommendations that are operational for our province to be able to improve outcomes. And so the policy analysis that we did mainly focused on parental substance use, family separation policies, gender-based violence, and child mental health. And we also wanted to look at what other sort of promising or proven practices were. So we'll be able to link some work that's already being done so we don't have to start at the beginning or reinvent the wheel. And so we looked at some of the sometimes we feel like this work is sort of intuitive. Like, of course, families need some economic supports. Of course, we need to protect against violence. But what we would offer is that there's other areas in the world, even some other provinces in Canada, that actually have a very deliberate framework around ACE prevention strategies, and that we would love to see that for New Brunswick. And so that's part of the case that we're making for today. And so the Center for Disease Control, this is part of the ACE prevention framework that you have there in front of you. And then another example would be like the California Surgeon General's ACE prevention strategy, and they talk about more of a primary, secondary, tertiary approach. So prevention, more going upstream, mitigation, which is my day-to-day work when I work with kids in the community, and then of course implementing trauma-informed practices. So we're able to kind of look at that downstream approach. So different ways that we can look at it depending on what works for us as a province, but really hoping we can come together on a strategy that really allows us to make an impact when it comes to the adverse childhood experiences. So let me tell you a bit about the PCAP results. So if you think of the women, and we sometimes use the term birthing people because not all of the women in the PCAP program identify as a woman. But for the sake of ease of discussion, we'll talk about women and mums. The average PCAP family includes a mum and two children. Their average age is 27 years old. Most are single, 90%, so lone parent families on average have a grade 10 education. We do the adverse childhood experience score on entry, and the average score is 6, which again, for those who may not be familiar, a score is out of 10, and if you have a score over 4, you're directly linked to some of those behaviors and physical and mental health outcomes, poor outcomes that I mentioned before. 94% identify being victims of abuse, and over half identifying the as having a chronic medical issue. And just a little note, they're only 27 years old, and we're talking about chronic medical issues already. On entry to the program, 95% reporting a family history of alcohol use and issues, 85% drugs, 86% mental health, and 72% of themselves having had some involvement in child protection. These are just quick hits. There's so much more data, you guys, but I was given 25 slides, and I'm sure you don't want to be here all day. It would take us a long time to tell you everything, but we want to tell you our big hits. So when women who are enrolled in the PCAP program, if they have a subsequent pregnancy, so another birth that happens during their time with us, we are so very thrilled to know that 80% of those births are completely non-exposed to substances, which is exactly what we were after with this program. And if they're enrolled in the PCAP program, 69% when they graduate at those 3 years are completely abstinent from substance use, which it's important to note is not necessarily a goal to completely give up your substances. We use a harm reduction approach. So we are thrilled if people decrease their use, particularly during pregnancy. And there are lots of substance related harms that we're again thrilled if they're not using their substances and having harms from those. But to have 69% completely abstinent from their substance just is a testament to how hard our advocates are working to get them enrolled in recovery programs, to get them enrolled in counseling, to really look at those goals and be able to have a reason to give up those substances, which a lot of the times the goals are related to reunification with children, leaving a partner that may have intimate partner violence, getting enrolled in education programs, getting a job. So these are really powerful outcomes for us. What do we do when they're with the PCAP program? You'll see on this bar graph is a list of the amount of, service connection that we have, which I mentioned already might include education programs, recreation programs. A lot of women want to get to the gym and start moving their body and feeling more healthy, but there's a lot of barriers for that. A lot of client health services themselves. Many don't have a primary care provider. And then it's been nice to be a pediatrician and be aligned with this group because a lot of now the babies and children who are born to the PCAP moms, maybe they don't need to see a pediatrician, but many do, and I get to follow them now in my clinical practice. For those of you who think about the alignment with justice, a lot of the women in PCAP have been criminalized. So if you look at this first circle here on the side, you'll see a lot of yellow and some purple there, which is about criminalization. So it's about arrests and convictions. And as we move towards the 3 years in PCAP, we'll see that there are very few convictions. And a lot of this has to do, again, with the type of crimes that women who use substances commit. And frankly, there's a mostly nonviolent crime, and a lot of the criminalization has to do with not showing up to court to be able to you know address some of their probation needs. And so again, having somebody to walk alongside them and really kind of clean a lot of that stuff up means that a lot of our women were able to move forward without that criminal history and without that issue, especially when they're looking for employment. So I wanted to talk a little bit again about some maternal findings, and I'm going to speak a little bit that's not necessarily on the slide, but just to address the slide things here. So alcohol or substance use during pregnancy. So all the women who come into PCAP, they have to disclose substance use or alcohol use during the pregnancy, and it's important to compare that to the general population. So only 7% of the general population actually discloses alcohol or substance use during pregnancy, but all of our PCAP moms, obviously, because that's how they get into the program. But I wanted to highlight here that 17% of those who disclose drug or alcohol use during pregnancy are actually in teen pregnancies. So what that means, if I've lost you, is that those who are using substances during pregnancy, there's a disproportionate amount of those women who are teenage pregnancies. And so you can just imagine that then as they go on to have more pregnancies, they're going to have more in their lifetime, and they're younger, and they actually have them younger than the general population. So it's just important to realize that, women who don't use drugs and alcohol during pregnancy, maybe they're in their 30s having babies, maybe they have one or two babies, but those who use substances are maybe youth, young adults, and they're having quite a few more. So this isn't a problem that happens in a generation that's 30 or 40 years in length. This happens in a generation that's 20 years. So for the math people in the room, exponentially becoming even more and more of a concern in our community. We need to know that, again, the women having babies using drugs and alcohol more are living in areas of lower rates of where there's post-secondary education completion. Remember, our women on average don't finish high school and have a grade 10 education, and are living in areas with higher maternal deprivation on all the subscales of the Canadian Index of deprivation. So just a very vulnerable group. We know that our group is more likely to need health services for mental health, specifically for mood and anxiety disorders and even schizophrenia. We know, in particular, chronic respiratory conditions and diabetes, the mortality rate is higher. And when we compared to the general population, there are similar rates of cancer and cardiovascular conditions found, but they're much younger when they have them. We know that women who use drugs and alcohol have a much higher adverse childhood experience rate themselves, which might explain some of their poorer outcomes. And when we look at the costs to the system, which we were able to do with some economic analysis, much higher in terms of healthcare costs. I'll just spend a second here just for the French translation slide. So let's talk about the kiddos. So when children are exposed to drugs or alcohol during pregnancy, we know that they have higher rates of preterm birth and lower APGAR scores. An APGAR score is a score that you get after delivery that's just sort of a snapshot in time about how well the babies are doing and kind of how the pregnancy or how the delivery went. But that's important because those babies are more likely to be in our neonatal intensive care unit at, I don't know, last time I checked, $3,000 a day, more likely to spend longer in hospital, and then, of course, the medical issues that go with that. We know that exposed children have a higher prevalence of mental illness, anxiety disorders, ADHD, neurodevelopmental disorders. We do not do a great job of being able to link to the fetal alcohol spectrum disorder diagnosis yet, although I hope that that'll be soon because I think that's drastically underestimated in a lot of our kiddos in the province. And then we were able to, with our data, construct sort of a proxy adverse childhood experience score. We can't get all of them, but we know that the babies who are being born exposed are actually like coming out with an ACE score of 2.7, and then they've got 18 years to increase that score. And so we know that they're really starting behind or really at risk already of those poor outcomes later. This is a nice picture to the side of Dr. McKenna, who also works in our Social Peds Pop Center as a pediatrician with me. For the education minded folks in the room, school readiness. So being able to link to that education data, we know that the exposed kiddos were less likely to even attend a preschool readiness assessment. So that's some of our IDA assessments. Among those that did attend, 20% more had scores indicating that they needed additional supports before they were able to go to school. So that matters from a DOH standpoint because that might include things like occupational therapy, speech language pathology, or others. And this was primarily for domains on the cognitive and child awareness for of self and the environment. And so it's important because, again, that social emotional piece may not be there, which can be so problematic when kids enter school. We know that they had a higher number of absences from school once they were there, and a lot of that was related to unexplained absences as illness and appointments were similar. So I wanted to just talk a little bit about some of the challenges and barriers being able to do this type of research here. I talked about how absolutely wonderful DataNB is and their ability to allow us to use some of that data comes from a lot of pre-work done with organizing data privacy and confidentiality, but there's still some issues that come up, in particular as we try to see DataNB be able to get new data sets. And so it's really we don't want just government data sets. I think as researchers, we really look forward to being able to jump into the community sector as well, which is why we offer our PCAP data and soon my clinic sort of pop center data into the data registry as well, so we can do sort of government and non-government data sets. Sometimes the quality and compatibility isn't quite there. Of course, we would love to be able to have everything on the same database and the same format and nice and clean. But that remains a challenge. If you think about just even how we collect data in our little pockets around the province, it's very technically complex. And because you need to literally kind of sit in a room, windowless room kind of thing to be able to work through some of the data and clean it, it takes a lot of manpower. It takes a lot of hours. You need a lot of approvals to do it. It costs money. The risk of bias is really because, of course, how well do we collect data on people who don't necessarily connect with the system as often as we would like them to? And then, of course, it takes a lot of time to be able to communicate and have that stakeholder engagement. So we know there's a lot of data out there, but we can't always look at everything and analyze everything. So how do we know that we're asking the right questions? And this is like a perfect room to know, are we asking the right questions for people who are making policy decisions, people who are making investment decisions. And, my very quick overview of some of the data we have, how can we move forward to interventions and understanding like the PCAP program? We showed you some of the amazing interventions that we think we did, but how can we do that really intentionally with the programs that you guys are supporting or that we would like to create and have your support so we're able to kind of, know that not only is the investment worth it in terms of a return on, actual economic investment, but social investment, but then also, of course, are people doing better day to day and are we making the system better? So, as we move into kind of the last bit here, I just wanted to do a plug for what's next after this. So, like I said, PCAP exists. It's ongoing. It's in the community. We hope it grows and builds. We want to see it in other communities in New Brunswick where there just simply isn't a lot of support for this population. I hope that I've proven to you that they are that putting investments into the support. For women and children or women who use drugs and alcohol during pregnancy is important. One little tidbit that I wanted to share is that when women disclose to us that they are using substances, they talk about the average age that they started using substances as between the ages of 11 to 14. That means that substance use and the problems that come with it are a pediatric problem. And so this Get Ready project that I have on the slide is about moving from, supporting the PCAP program, which needs to keep going, to really understanding where our early years children and youth interact with the system and how we can create a data framework, which is what we're proposing here, to be able to look for all those intersectoral connections and be able to really be prepared to ask questions like, if you implement a program, like I'll use ours, like, going to MB Social Pediatrics, the POP Center, does that mean that kids do go to school more and have better attendance? Does that mean they use the emergency department less? Does that mean that they're more likely to graduate? Does that mean that they're less likely to be in the juvenile justice system? We want to create a very robust data framework so you guys can ask those and answer those questions very easily. And so if you see some people in the room even will be like part of the team for that, that's what we want to move to next. A lot of our PCAP kiddos are in my practice now. And so we really want to be able to move the needle for their outcomes in the future. So that's the Get Ready 0 to 20 project. Thank you very much for your time today. I didn't have as much time as I would have liked to really get into the weeds, so it was the quick hit. So hopefully you have some questions, or if you have specific things that you want to ask myself or Natalia or Sarah Lenny is our research coordinator here with us today as well, to be able to answer those. We'd love to talk more about it. And if you guys want to hear any more about this in an offline conversation or come visit our sites, then please reach out anytime. And for those of you who get to hear me talk often, thank you for listening again, and hope to see you all again soon. So thank you for your time today.